Are you ready to go live? Okay, great.
We're live right now.
Oh,
Welcome everyone to our monthly Alliance HOSA guest speaker session. We're so excited to have you here with us tonight. We'll get started in just a few minutes, so feel free to say hi in the chat while we wait. We'll just wait for more people to join and then we'll start. Okay, so we can go ahead and begin.
hi everyone. I'm Sathvika, one of your HOSA committee chairs, and I'm so excited for tonight's event. We're so excited to welcome a fantastic guest speaker who will share her journey in internal medicine. Before we jump in, just a quick reminder that there'll be a QR code at the end of the session for attendance, so be sure to stay.
And I'm Krish. For any new members joining us, HOSA is a student-led healthcare organization designed to prepare future healthcare professionals. Through our Alliance Academy chapter, we bring in monthly guest speakers from a wide range of medical fields.
Without further ado, tonight's guest speaker is Dr. Ajala. On behalf of Alliance HOSA, we're so honored to have you here, and we're so excited to learn from your experience. To start us off, could you please introduce yourself and tell us a little about your role and field of work?
Sure. Hello, everyone. Good evening. Thank you for joining us. My name is Dr. Kalisha Ajala, and I'm an internal medicine physician, specifically a board certified internal medicine physician. I am a hospitalist at Grady Memorial Hospital, and that is in connection with Emory University School of Medicine. I also am an assistant professor of medicine at Emory within the School of Medicine, and I teach medical students. I do a lot of other things, so I guess I should talk about those as well. Within my dual roles of teaching med students from their first year until graduation in the classroom, I also teach them at bedside along with our trainees, which we call residents, and there's a reason for that name. And these are the ones who finish medical school but are training in their particular field. And I also see patients in the hospital on my own. The term hospitalist is a little different from obviously internal medicine physician. And that basically means that I see adult patients. And for us, adult starts a little bit early, but basically adult patients versus someone who sees little kids or someone who takes care of pregnant women, specifically, and there are other fields within medicine: radiology, anesthesiology, surgery, etc. So internal medicine is the internal workings of an adult. And so I see those patients, but many internal medicine physicians can see patients in the hospital and in the clinic. I see them specifically in the hospital only. I don't see clinic patients or primary care. And so that means that when a person is sick enough, unwell enough to have to be seen in the hospital for things that could be considered emergent issues that they have to be monitored for, I help care for those patients. And I do also work in global health and community health as well, because I have a nonprofit that serves the community in a health education way. And that's pretty much it.
Wow, that's really amazing. On top of being a physician, having a nonprofit, teaching students, that's wonderful.
Thank you.
To dive a little bit deeper into career journey and exploration, can you walk us through your career journey and what led you to choose this path in healthcare?
Great question. What led me to this path, to be honest, is I have a heart for service. And I'm from Baltimore, Maryland, on the East Coast. And I grew up just on the borderline of Baltimore County, North Baltimore. And I have family all over Baltimore. My mom is a recently retired nurse who worked at University of Maryland. And within my family, I'm losing count at this point, but I'm either the sixth or seventh doctor on my dad's side of my family. And I think that, learning about the other people in healthcare, their, I would say, like their passions in medicine, I kind of found my own in that I wanted to make sure that I serve the needs of the community in a more immediate way. And so that would mean for me in the hospital, because to be quite frank, as it has to do with what's happening in healthcare, or what continues to happen in healthcare in our country, and honestly in countries around the world, a lot of times when people need help, they hopefully are able to see a primary care physician, but a lot of times they go to the emergency room, and if they are quite sick, they end up having to stay over and be cared for in the hospital. And so for me, that was a very direct way to care for patients. And so, people who have had heart attacks and strokes, and, have diabetes and heart failure that, is not well managed, those who have life-threatening illnesses and seizures, et cetera. These are, very acute issues that I had come about to, learn about. And I realized that, hey, like I should seek to try to take care of these patients. So I fell in love with management of patients in that way. And then I guess the other part I would say that I found to be very important, that kind of led me down the path of working in global health, and that is specifically in Ethiopia, in Ghana, in Thailand, and India. India is the last place I have been. Doing that work around the world, I think that has been informed by my Nigerian background. My dad's side is Nigerian. And so you tend to learn that, honestly, the world is one large community. And if you can serve at home, then you can also work to serve abroad, and partner and learn from others in other communities. And as far as teaching medical students, which I've done around the world and also at bedside, I would say that my journey in teaching comes from me thinking about the things I wish I'd learned, and the way I would have hoped that someone would have held space for me to learn. And so, sometimes the drive, as far as becoming a physician, sometimes is wanting to treat patients the way that you believe they should be treated. And in teaching, sometimes it's teaching the way that you wish you have been taught.
So, did you always know this field was for you? And if not, how did you figure it out amongst the many paths in medicine?
Um, it's interesting concerning that. Let me just make sure. Are you hearing anything in the background, or is it clear?
It's clear.
Okay, cool. Um, so interesting. I initially, okay, it was a point in time where if you wanted to be a physician in Baltimore, there was a specific physician who was a pediatric neurosurgeon that we learned about, and you wanted to possibly be like him. There was also a physician who ended up, I come to find out later, attended my college, and he helped to create the heart defibrillator. So, when you're young, and sometimes even when you're older, but when you're young, you think about the heroes that you see. And for me, I thought maybe I want to be a neurosurgeon. And this particular doc worked at Johns Hopkins. The other doc also worked at Johns Hopkins. And my thoughts were, okay, I want to be like them, when I grow up. And as I continued to grow, middle school, because, okay, I wanted to be a physician since I was 7, and I was so serious about it. And my family, they were like, "Oh, that's it's cute that she wants to be a doctor." And then I get to middle school and I still want to be a doctor, and they're like, "Okay, well, you can be anything that you want." And starting in, I think, about 7th or 8th grade, I started writing Dr. Kalisha Ajala in all my books instead of writing just like my first name or last name. I wrote Dr. Kalisha Ajala. So I've been writing it for a very long time. And when I got to high school, I was still pretty serious about it. So they were like, "Oh, she's pretty serious." But I think it evolved from wanting to be a neurosurgeon, then to maybe OB-GYN, and or surgeon. And I think that came from the shadow opportunities that I had when I was in college. I was able to shadow a family practice doctor who also delivered babies. And I was also able to shadow a cardiologist, interventional cardiologist. And so sometimes the people you shadow, you become so excited about the work that they're doing that you want to be just like them. And when I started medical school, I realized that I wanted to do something that served the community as a whole. So I thought I wanted to do medicine, but see patients in the clinic and in the hospital. And then I realized that clinic wasn't for me, which, is different for everyone. And I ended up landing on wanting to work in the hospital only when I was a resident, finished med school. I was a resident, and I worked at Grady Memorial Hospital as an intern, and I fell in love with that hospital, with the patients, with the people who worked there, and just the vibe of the hospital. And as I worked there, I realized that a lot of my patients were from around the world. And then I thought, okay, I definitely want to continue to work in the hospital. I want to work at Grady, but I also want to connect with people from around the world. So if possible, while working as a hospitalist and internal medicine physician, if I had the opportunity to go and work around the world, I definitely would do it. And I love to travel. Once I finished residency, I was an attending physician. I had an even better schedule and I was able to travel the world. And I thought, well, if I like traveling, I like DJing. I'm a DJ as well. I like traveling. I like DJing. I have a nonprofit. Why can't I just go and maybe connect with hospitals and or clinics around the world, and maybe I can spend a little bit somewhere, and I can also help with seeing patients, or I can learn about how medicine is practiced in various places. And that's how it evolved. I there when I decided not to go into surgery, I know it shocked a lot of people, because a lot of people thought, she's very driven. She has a particular type of personality that, she would excel at surgery. But that same personality, I believe, has been applied to my work uh, in the hospital, around the world, in education, and within my nonprofit. So, yeah, I think it was a natural progression. I would say, and you may ask me about this later, even when other people kind of see a lane for you, or they think you should practice a particular type of medicine, or they think that you should become something totally different, I think it's very important to follow your heart, because I would say I'm very happy in what I do.
That's great to hear. What were some of the challenges you faced during college or like earlier in your career, and what kept you motivated throughout those times?
I have this book. I think it's upstairs, but it's called Cell Biology. Oh, cell biology. I have pretty good grades in college. I transferred from Grambling State University to Tennessee State University in my sophomore year at a 3.98. And I got to cell biology and I was like, oh my goodness. It was and it could have been part of who was teaching it maybe, but at the end of the day, it was a tough course. And it incorporated biology, chemistry, biochemistry, and the quizzes were just really, really tough. And at the time, I think, because in my freshman year, I took 14 and 19 credits. And then my sophomore year, I was taking, I think, 21. So taking 21 credits was probably my own challenge. I did that to myself. Should have done that. And cell biology was probably one of my tougher ones. Organic chem was a challenge. You probably were asking about general challenges, but I'm just telling you about the ones that like really had me calling home like, mommy, oh my goodness. And interestingly enough, as it has to do with cell biology, to this day, when I'm teaching my medical students, it's one of the areas that I find myself to be very strong in. So it's kind of interesting when, I'm talking about the cell or talking about how the cell functions, or I'm talking about physiology, which involves, if you're talking about like NAD or you're talking about sodium, potassium channels, et cetera, like I still understand that because of how hard I had to like study those courses. So I would say some of my challenges were sometimes you find, and for many who want to go into healthcare fields, I'm sure you're pretty bright and you might find that certain things come quite easy to you, when you study and you kind of pick it up and you're able to memorize and understand certain things. And I think for me, it was one of my first challenges where I was like, wow, I'm not immediately committing this stuff to memory. Like, wait, me? Like, I can pick it up, I can roll with it. So I did well in it, but I was kind of humbled by the challenge that it was. And I remember organic chem also being one of those challenges, because gen chem was fine. So I did well in that. And then I took engineering physics. I don't know why I decided to take that instead of regular physics, but I just thought I was a baller and I was just like, whatever, I got it. And so I found that the bigger lesson as far as like overall challenges um, was that if you hit a bump in the road and things don't come as easy to you, continue to believe yourself, press and work through. And I would say in medical school, um, you get through, undergrad is really tough, but once you make it into med school, it's the high amount of information that is being thrown at you in multiple courses on top of doing anatomy, which is when you work with a cadaver who was once a person who decided to donate their body to science. And you're learning about the human body in real time. So you're holding a heart and a brain in your hands and you're dissecting. At the same time, you're learning what you learned in college, say in a month, you might go through that in like a couple of weeks in med school, maybe a few weeks, a couple of weeks probably. And so I think the challenge in med school was adjusting to the amount of information that I had to understand and believe in continuing to believe in myself. And I would say in residency, a big challenge was when you realize I have an attending physician, I have a boss physician, but as the intern, I'm the doctor now. So like as a med student, I could go and ask the intern and go and ask the resident. But at this point, I'm Dr. Ajala, but I just finished med school. And you're faced with, questions from the nurses and sometimes some challenges that you're unsure if it is your responsibility to really know that information. Is it a failure for you to not be able to answer those questions to the nurses and the patients? And there were some life-threatening things that happened to patients, and so we had to, and you all may have learned about, like, doing basic life support, um, advanced cardiac life support, those types of things. And so trying to save a patient's life in real time becomes a even bigger challenge. But I think the stepwise, my challenges, I would say, have been making sure to believe in myself and give myself room for growth and be okay when I don't know something and not be afraid to ask for help.
That's some great advice. What does a typical like for you current position?
The typical day would start at 7 a.m. Well, that's when you arrive at the hospital. You probably want to get up at about 5:45, but 5:45, 6 o'clock, 6 a.m. And so as a hospitalist, we have every type of doctor has different schedules. An inpatient physician, we a lot of times work 1 week on, 1 week off, and that's 1 week, 7 days of 12-hour shifts. So that's like 80 something or so hours in 1 week. And so that day would start at 7 a.m. and it usually will end at 7 p.m. And so you arrive at the hospital and you have patients that are assigned to you that are admitted for heart attacks and strokes and seizures. They may have had some chest pain and need further workup. They could have had surgery and need to be monitored. And you will be working with physicians from various fields. It could be a physician from surgery, from orthopedic surgery, neurosurgery. It can be just about any type of physician. And so you take a look at your patient list, you look at their labs, why they're there, what's going on with them, what the nurses noted overnight, and then you go see your patients and you meet them at bedside and you do physical exam. And before you do all of that, you just greet them, right? And you introduce yourself, make sure it feels like a safe space for them, see how they're doing, and then you'll do your exam of the patient and make your recommendations for what you want to happen next. And for some patients, they're there for days. For some patients, they become very sick and it can be quite unpredictable. And you might be in situations where you need to do, life-saving measures for these patients, and making sure that they are safe and they are progressing. And we also take in new patients, discharge patients, send them home, educate patients. And again, this is, not a clinic setting. This is like, people who are admitted to the hospital. And then, I also, if it's not just me with my patients, I may have a huge team of residents and medical students, which some of you in a few years will be probably, medical students that I'll work with. And my team can be as large as like 7, and that'll be intern, resident, various levels of med students, PA students, physician assistant students. And we'll go see the patients together and we'll work with them and take care of them and bring in new patients until 7 o'clock at night. The thing of what I just said sounds really streamlined and predictable. Nothing about that is predictable. Like nothing. Um, there are shows that don't really, I don't think, fully reflect, but they try to. So like if you watch something like a Grey's Anatomy or a show old back in the day called ER, where like there's these, or House, where these, interesting cases or not predictable cases where you see doctors like just running in the hallway, that happens for various reasons. So I would love for a nice predictable day, but I've really not seen that. And then other parts of my day may include me also on an off week. It may include me going to the School of Medicine and teaching med students in the classroom. And that may be, teaching them clinical reasoning. And then another day might be me teaching them how to perform physical exam. which we're very big on at Emory, clinical reasoning and physical exam. And I still might drive over to the hospital and do other things. So it's a bit both. Um, and that's usually a typical day. I want to throw in a typical day in global health. After flying to, so in India, I was able to teach at a Tibetan medical school that was opened by the Dalai Lama, His Holiness, and was able to teach there. And um, a typical day there would include waking up, getting a ride to the School of Medicine, teaching the med students. But the thing is, the way that they learn medicine is more Eastern focused. So they don't use stethoscopes. They do study pulse. They do various things. And so we teach them in the way that we learn. And they teach a bit back to us. And we're able to kind of tour and study under some of the physicians there. I was able to shadow the Dalai Lama's physician for half a day, and I learned so much from him. He's been practicing for 30 to 40 years now, and the way that he taught me about certain things within Tibetan medicine, his technique of teaching, I was able to learn from that, and not necessarily Tibetan medicine, because I'm teaching allopathic medicine, but his patience and just the way that he was able to educate me, which is a skill in and of itself. I was able to bring that type of technique back with me and had one of like my best teaching times. And lastly, I'll say if I was in Ethiopia, we would go around on patients just like I would do at Grady. And in Thailand, we set up an entire clinic in a covered outdoor space. We set up our own like pharmacy with medications that were approved that we purchased for the children. We saw about 150 people, 50 adults in one clinic, 100 children, and people who lived there in another clinic. And we had little stations where there are physicians and med students who would help screen the patients and take their vitals. And then we had two translators that would allow for us to ask them what their complaint was or how everything was going. And then we would do physical exam and write any referrals for any other things they might need, or order for them just very simple approved medications. And this was all like outside, and it would be about 90 to near 100 degrees, but it was fine. It was covered. We would do that for just under half of a week and celebrate and then go home. But lastly, I'll say the similarity between like a day at work at Grady. First of all, I'll say that our lights work. We have running water. There are some hospitals and clinics around the world that do not have running water, that do not have working lights. People a lot of times have to purchase their medications before they're given to them. And here in the US, it is offered already. So I've learned gratitude from that. And then lastly, in comparison to around the world, one thing I've noticed in Thailand was when I finished seeing a patient, which I was really grateful for them to allow me to care for them, they always thanked me in a form of namaste. And it made me so grateful to be in community with them and care for them. So much so when I first would get back to Grady, after every patient encounter at work here, I would end this way and my patients would be like, wait, what's going on? I'm like, oh, sorry. Like, because I was just so used to what I had learned in Thailand. But I would just tell them I'm just, very thankful for them allowing me to care for them. But it's quite infectious. Yeah.
So, what type of patients do you typically work with, and what's one of the most common cases you see?
I see a lot of adults who I've seen some younger people too who are, in their late teens. There's various types of common cases, but to keep it short, I would say adults who may have limited access to health insurance, and some have great access. But there are sometimes folks who, can't afford their medications, and um, they may, hmm, ours are pretty complicated patients sometimes, but basically, and not the patients, but like their conditions can be complicated. So we may see a patient who may have diabetes, who may also have high blood pressure, um, who may also have what we call maybe heart failure. And this is kind of a, a common thing that you'll see around the US. But sometimes those are sometimes our common patients who also may have their kidney function may be compromised because of these things, because of the diabetes and the hypertension. And so they, may have these common chronic conditions that um, would be better served if they had great access to be able to afford their medications and access to um, closer monitoring under physician care. And so Grady has worked very hard to increase the amount of clinics that are in Atlanta so we can try to prevent people from having to come into the hospital, because the things I just told you, or the conditions I just told you about, shouldn't have to land you in the hospital, right? But if you struggle to manage them well, your blood sugar, your blood pressure, it could lead to a weakened heart. It could lead to a stroke. The diabetes can, cause your kidneys to have struggles, cause blindness. And so, in short, that probably those conditions uh, lead to some of the most common patients concerns. But the reason why they'll become admitted is because their blood pressure can be so high that it could possibly lead to stroke. It could possibly cause other issues. um, and so a mix of those, where a person can become sick enough to have to be in the hospital for those to be managed. I think that was the key question, right? So what do I see mostly? Yeah,
Yeah.
or a common one, because I see other things. There's sometimes I have to note patients with AIDS, who who may have been diagnosed some time ago or did not know, and should be on therapy to control the amount of the virus in their body, and thus allow for their T cells, which are fighter immune cells, to prevent other illnesses, but may struggle with having access to those medications and may come in very ill. And AIDS, I'm sorry, is acquired immune deficiency syndrome, for those who may not know what that is. And at this point, it's a pretty manageable condition. And but people do need access to testing. They also, need access to medications, and they need access to someone to help manage it. And so you could see someone who's quite young, who has their whole life ahead of them, who needs these medications and can come in needing help with that.
Have you had any memorable or life-threatening cases to you?
For sure. I've worked in other hospitals in the city outside of Grady as well. I worked in other community hospitals for 4 years before I came back to Grady. So, a life threatening condition that I've seen many. In the sense of, and I'm not laughing at it, I'm smiling in the sense of just strong faith and the idea of hard work, and also partnering with our patients, their families, um, to get them through. And I've seen so many. I've seen conditions where there was one week where there were 3 instances in one week of um, 18-year-olds or 19, very just late teenagers who had come in with unintentional overdoses. And this was because they had been with friends at a party or just hanging out with their friends, and they thought that they were taking medications such as Xanax. They thought that they were taking, and these are not prescribed by their physician. These were like things that their friends were handing them. And so that alone, should be discouraged. Um, because many of these were street drugs, meaning that they were manufactured elsewhere and sold on the street. They were not prescribed by a physician and picked up through a pharmacist. And so their friends were able to score them in some way, shape, or form in the streets illegally. And in 1 week, we had a person who had taken Xanax, another person who had taken Xanax, and another person who had taken Percocet, which is oxycodone and Tylenol, a mix. And all three of them, just by taking equivalent of, I guess, like one pill of those things, had lost consciousness and were not able to breathe very well on their own. And they were found to have fentanyl in their systems. All three of them, unrelated, did not know each other. And all of them were young. And they had to be given Narcan and other medications to try to bring them to consciousness. And one of them, because this person just really could not come out of it with all the medications they were trying to give them to help wake them up and help them to breathe on their own in the field and even in the hospital, had to have a breathing tube placed down to the lungs to help this person to breathe. And they were placed on what we call a ventilator to help them to get oxygen to their brain. They were able to wake up a little bit later, going into like the next morning, and they were able to pull that tube, and that person was able to breathe on their own. But they really scared their parents. And, we were worried as well because, people overdose and die. And so it is always very shocking. We have many protocols in place and we know what we need to do to try to save a life, but it's very, I would be honest with you, it's shocking, and it still is scary. I know what to do. Like, we need to give Narcan, and you may give something intranasally in the field. You may need to give it IV. You may need to place the person on a drip just to keep them awake, especially when they have something like fentanyl in their system. Um, I've not been in a situation where I've specifically witnessed a loss of a patient in that sense, but we've had some really close calls, and these were very young people who thought they were taking something that was harmless. So to that, lastly, I would just say, if it's not prescribed to you, please do not take it. And if you're not on those medications for anxiety, for pain, why are you taking it? Please don't. And you're a lot of when I had these conversations with these young people, they noted that they had gotten it from their friend, and so you trust your friend, apparently, right? But you don't know who your friend got it from. And so that can land you in a hospital, waking up a day or so later, or that night or whatever, wondering how you got there. And the key thing is that you're really lucky and blessed that you woke up, and you were found early enough. Um, but I'm to be honest, like this is not just because I'm trying to give some warning or something, because I am in a sense, but that's not why. It really shocks me when we have to witness that. We move fast, and thank God for emergency medicine services, EMS, and what they do, and our emergency medicine physicians. But those are very unforgettable cases.
Are there any common misconceptions people have about your profession or field that you'd like to clear up?
Internal medicine, I think that people may not exactly know what we do, to be honest. But internal medicine, we're adult physicians, and I am a hospitalist. I would say I would broaden it out um, as far as the field of medicine. I think there's still misconceptions, and I know people have their own experiences with physicians in general, but there are misconceptions that doctors don't want to be on your side, and many of us, we are pulling for you in ways you may not know. We really do care, and so many of us, we dedicate our life to a life of service. And I know that there are varying opinions about that, but we still, you know, we take an oath, and we do our best to try to live that oath. And that oath is to do no harm.
Are there any like certain skills that people need in order to succeed in the medical field or internal medicine specifically?
Internal medicine physicians are considered the nerds of doctors. I don't mind being called a nerd, but we're considered the nerds. And To be a great internal medicine physician, I believe that it does require curiosity and understanding that you must listen to your patient. I had an attending who used to say that to me all of the time. You must listen to your patient in the sense of you taking a good history and understanding what brought the patient in, what led to their symptoms, and doing a great physical exam, and having good clinical reasoning. And the reason why I say it starts with you must listen to the patient, because a lot of times biases can happen where you think you've seen a particular condition a million times. So you just kind of assume, oh, this must be a simple, it could be a chest pain, it could be anything. And if you listen to the patient and really honor their story and what they're telling you, and honor what their body is telling you through this physical exam, it will help lead you to where you need to go and maybe even who you need to call. Um, I think that probably, I don't know, that's the most important. And then I think overall, as far as like getting into the field of medicine, um, a good piece of advice would be remember your why. Um, and what I mean by that is for those of you who want to go into nursing, or go to PA school, or go to medical school, whatever your field is that you're interested in, remember why you wanted to do this, because you will have some challenges in college when you take the whatever placement exam you need to take, when you get into that school, and get that training. And as you move forward, you'll continue to basically have just life challenges. But in remembering your why, it could be a family member, it could be one time where you volunteered a particular place, it could be what happened to you as a young patient. Don't forget those types of lessons when you have a patient in front of you, because that'll help you to remember what it was like or why you decided to do what you want to do. And it'll help you to advocate for your patients. And every person who is a physician of any kind, including internal medicine, should always advocate for their patient by getting their history, by listening to the patient and not assuming what their answer is, believing them when they say that they're in pain, believing them when they say they have a particular symptom, perform the physical exam. When you order the test or you decide that they need to have certain consultants for certain procedures, partner with your patient and don't talk down to them. Don't leave them out of the decision making, and involve their family if that's what they want, and make them feel seen and heard. And that'll, like, really, in my opinion, will lead to really good patient care.
What high school or college course helped you the most in preparing for your career? I know you mentioned cell biology.
Oh my goodness. Yeah, cell biology was fun. Um, See, I'm still triggered. I don't know. It's never gonna go away. High school, I mean, biology was great. Chemistry was cool. Um, I will say that English was one of the best courses, and I took English 1, 2, advanced, all the things. English helps with clinical reasoning or just reasoning in general. So when you're taking, for instance, I'm in medicine. So when you're taking like the medical college admissions tests, or really of those, any of those types of admissions tests, you need to be able to read and reason. And I think English really helps with that. So those courses, and then as high school, within college, biology was still very great. I feel like cell biology and biochem were very important, as far as physiology. It was a great grounding for physiology in med school, and physiology and pathophysiology are huge in medical school. And you end up carrying that into your field, especially if you're internal medicine, because again, we're the nerds. And I really loved anatomy and physiology. Some people are able to take portions of it in college. And if you are able to, or you're in it, please try to enjoy it, because it's so much fun. And I enjoyed anatomy, excuse me, in medical school. It was tough, a lot of hours, but especially, if you're interested in surgery, even if you're not, even as an internal medicine doctor, even as a radiologist, it's very important for you to be able to learn those things. So I would say those, if you're in college, physics is still very, very important because it's on your medical college admissions test. Can't get around it. So know it. It's not going anywhere. Oh, one other thing. It's not a course, but being able to volunteer. And if you have the option to volunteer and work with patients in a volunteer capacity, I think working with patients in a volunteer capacity can be really helpful to give you an idea of what it looks like to interact in a healthcare setting, and to see if that portion of it is for you. Some people, they find that they're able to do those things and very great with patients, but they want to go into radiology, where there are portions of radiology where you don't really do a lot of patient interaction. And they may choose to go that route. Is a possibility, but you will interact with patients in PA school, med school, nursing school. It's not going to go away. So if you have the opportunity, and we do look for people a lot of times who are able to volunteer and work in those, volunteer in those settings. So I think, although that may not be a part of your college or high school formal education, I would recommend it if you have an opportunity.
What qualities do you think are essential for someone entering your field of internal medicine?
Sorry, could you say that again? You said which qualities are essential for entering the field of internal medicine?
Like, what qualities do you think are ideal to have?
I kind of spoke to a little bit before, but curiosity, um, empathy, kindness, a strong work ethic, and to be honest, the ability the strength and or ability to study and study smart. You can read something a million times over and absorb nothing, but learning how to study smart, I think, is very important. But I think those are the key things. You can have the best grades in the world, but for internal medicine or just to be a physician in general, you need to have empathy and kindness to interact with your patients.
If you could give your younger self a piece of advice, or anyone who wants to pursue healthcare, what would it be?
Um, my younger self. I think I kind of said a little bit about it, but remember your why. Like, really think about why you want to do this, because at various stages of my career, I've been a practicing internal medicine physician since uh, mid 2013. So that's 12 years. I would say that I have had to revisit, not because I forgot, but you can re-inspire yourself. You can continue to be inspired by understanding your why and understanding why you became a physician, why you wanted to become a physician. And again, your story could start with a family member. It could be something that you've experienced. It could be something that you read about. It could be a cool procedure that you've seen. It could be a parent or family member. But whatever the reason, and that reason can evolve over time, but it will carry you forward in the more difficult times. Because to be honest with you, there are some times where, you know, studying the field of medicine can be tough, right? I mean, college is tough. Studying organic chem can be tough. Biochem can be tough, right? So there are certain things, studying for MCAT, like all those things can be tough. So you need to remember your why and hold on to that, because you're going to revisit it. Trust me. I think that's the best advice. Remember your why.
Do you see yourself to grow in your for new specializations in the future?
He's breaking up a bit. Could you tell me what his question is?
Do you see yourself continuing to grow in your field through further training or new specializations?
Okay, gotcha. Um, I see myself growing in my field in the area likely of point of care ultrasound. Um, that's a very specific. So basically, ultrasound. For those of you who may not know, there is something we call a probe. It doesn't go inside the body. You can literally basically take a particular apparatus, place some gel. Some of you may kind of get what I'm saying. Place some gel on the patient's body, and you're able to see things that are dense and things that are like water. And those things that are dense, like the body's organs, have a particular shape, may have a particular function, and things that are more like water or things that are more like air, you'll be able to see. Those being able to do that at bedside, point of care ultrasound, meaning right at that point, you're able to perform said ultrasound and with a very small machine, small instrument. You are able to at real time be able to see if a person has fluid on their lungs, and could that be the reason why they're short of breath. You would be able to take a look at their heart and structurally be able to ascertain as to whether there are issues with the structures of their heart, which could be the reason why they're having other complaints. You could see if a person has fluid on their knee. You could take a look at a person's liver. You can look at their kidneys. I was able to teach a bit of point of care ultrasound when I was at Minsi Kong, the Tibetan medical school in Dharamshala, India, and they really enjoyed it. And so within that field, you can continue to learn point of care ultrasound, and you can also do procedures. And certain procedures are very simple ones that could withdraw fluid, et cetera, et cetera. So there are ways to do procedures. I'm not sure if I want to move forward with doing particular procedures, but as far as imaging in real time at bedside and being able to better ascertain what's going on with my patient, I want to continue to grow in that particular area. So at bedside as a hospitalist, that's one particular thing. And as someone who works in global health, I think that this can, and there's work that's already happening with point of care ultrasound in global health. But if we are able to teach physicians, honestly, around the world who are able to go into their communities that may not be very close to a hospital, they may be able to, in real time, have a better idea more immediately about what's going on with their patient and their patient's complaint in real time. And it could help them to, as we call triage, but basically it'll help them to more immediately have an understanding of if something is more emergent and if they need to be driven to village nearby for treatment, et cetera. This doesn't replace radiology images such as CT scan, and MRI, and X-ray, but it can give us some idea in real time of like how we are able to ascertain what could be an emergent situation for a patient. So I see myself continuing to grow there, being able to teach that and see the light in others' eyes. When they were able to see that it was, and I also was able to help teach it in Ghana as well, at a med school in Ghana, and just to see how much they enjoyed it was just like so great. And so yeah, I think I want to continue there.
So that concludes today's guest speaker event. We want to thank you on behalf of Alliance Host for the time out of your day to answer our questions.
Thank you so much, Dr. Ajala,
Thank you.
for joining us. We truly appreciate it. We're now going to display the QR code for attendance. Please make sure you complete the form by tonight to receive your credit. Also, a quick heads up, this will be posted on our YouTube channel. And thank you for everyone who joined. And have a great night.
Thank you.
Bye.